All right. Hello, everyone. Happy Tuesday. Welcome to a family medicine virtual morning report. I'm really excited for today's session, and we have three wonderful guests, all from the University of Rochester, who are going to be making this family medicine VMR happen today. Their names all happen to start with the letter J, which is also pretty exciting. So one of the co-discussants is Jazz. Jazz, do you want to unmute, introduce yourself, and maybe you can, have the pleasure of introducing our two other guests today.
Yeah. So my name is Jazz, Chief Resident at the Family Medicine program at U of R. I think you guys, some of you already know me for presenting cases here, and I'm super excited and a little nervous for being a discussant today, but I'm a little bit reassured that I get to do it with Jeff Harp, who I'll leave him to do his own introduction, but at our program, he's known as the Batman. The reasoning behind that is when Gotham needs saving, we usually return to him to come help us out. So I'm reassured that I'll be discussing the case with Jeff. I think Jeff at our program is well known for literally the jack of all trades, but also the master of a lot of them too. So he's the only person in our clinic that has signed off to do thoracentesis. So in the outpatient setting, which according to him is something that he was used to do when he was like a few years, couple decades ago. So the other thing is Joel, who will also get him to introduce himself as well. I have the pleasure of being his chief. He's a third-year family medicine resident who's also interested in clinical reasoning and hospital medicine. But his work ethic speaks volumes of how much of a hard worker and team player he is. And how intelligent he is kind of making me why I'm a little bit nervous today, because I have a feeling his case is not going to be a walk in the park. So I'm excited to have my two friends and colleagues here with me today. So plus I'm very happy to see all the VMR community here today again too. So hopefully this is a great learning case for everybody. But I'm going to turn it over to Jeff so he can start off with his little introduction that if he wants to give. And then Joel.
Much to say, I'm a family doctor. I've practiced full spectrum family medicine for most of my career. I'm currently concentrating on being a hospitalist. Jazz and I have done a lot of education together. We did one of these for our local community for Grand Rounds, did an unknown last year. So looking forward to it.
I just want to add, when we did, so this is both Jeff and I's second time ever discussing a case. And the first time we were 0 for 1. So we both have a chip on our shoulder today.
Thanks for the intro, Jazz. I don't have a lot to add. I'm third-year resident. I really love morning report style presentations. It's part of what was a driver for convincing me to pursue hospital medicine, which I'll be doing after graduation. So I'm just really excited to talk through this case. I've learned a lot from Jazz and Jeff. They're the kind of people that I'll continue to text later on in my career as the questions arise. So we'll see how they do with this first mystery test. Shall I get us started?
Yes, please do. We can have Amanda, you can go ahead and share your screen, and yeah, you can go ahead and get started.
All right. So my patient is a 66-year-old male who presents with shortness of breath. And for the first aliquot, I'd like to go through the HPI and give some medical history to help our discussants narrow down, and maybe they could come up with a bit of a schema after that for their approach to this chief complaint. So this began about 4 days ago. Not a hyperacute onset, but fairly sudden. I've noticed it develop over the course of a couple hours, and it was progressive, especially by the time the last 2 days, which is why he decided to come to the hospital. Having a lot of difficulty with any type of exertion, going up one set of stairs or downstairs, having to sit down often when walking around the home. He just walking into the emergency department from the parking lot was very difficult for him, and he's never had symptoms like this before. He was not having any trouble lying flat. He sleeps with one pillow, even over the last 4 days. It's been unchanged. He described some mild swelling of his ankles over the last 2 days. He's not been coughing except a small amount in the morning, which is not unusual for him. Noticed some slight abdominal pain today, no nausea or vomiting. He said he's been eating and drinking normally up until today when he's been having less of an appetite. Has also had a headache for the last 4 days that he described as mild to moderate, comes and goes. No constipation or diarrhea, no fevers or chills, no sore throat or congestion, no sweating, no dizziness. He was recently out of town. He went on a drive, that was about a 5-hour drive to Pennsylvania about a week ago. And then he returned also a 5-hour drive yesterday. I asked him about history of blood clots, which he said that he did have a history of a blood clot, but we looked through the chart together and found that what he was talking about was an abscess years ago, and he never did have a history of blood clot. He takes NSAIDs once or twice per day that he's been doing the last 4 days because of his headache. He smokes up to 3 cigarettes per day for many years, no recent changes, denies any pulmonary history like asthma or COPD. That's the majority of the HPI. His medical history is fairly brief, so I wanted to include that as well. The pertinent medical history is that he has a history of cholangiocarcinoma, but status post Whipple 2 years ago and on maintenance chemotherapy with capecitabine. For those who don't know what capecitabine is, like me, it's an anti-metabolite chemo drug that inhibits DNA synthesis and also RNA and protein synthesis. His allergies are non-contributory to seasonal. He has a family history of a paternal grandfather with stomach cancer. And his social history is the years of smoking. That was a very light number of cigarettes, less than 5 cigarettes per year, but has been doing that for about 30 years. Social alcohol use, no drugs, and he lives alone and is a part-time handyman and painter. And then I wanted to stop here to get some initial thoughts from our discussants.
Great. Jeff, if it's okay, I can get started and you can add it on. Okay, perfect. All right. First of all, Joel, I want to say thank you for explaining what I can't even pronounce it.
Yeah.
Capecitabine is, because I would not have known. So thank you.
Mhm.
That was very kind of you. So it seems like we have a acute onset of dyspnea in a elderly individual. I guess my first approach here is like going through the dyspnea pyramid, but certain clues here that makes me wonder the etiology. So obviously when we're thinking of dyspnea, we want to think about, is this the heart and the lungs? And then is this a severe anemia? I'm not getting a picture of a severe anemia just by the very brief HPI that we have received, meaning like no, he hasn't noticed any hematochezia or melena or anything like that. But obviously we'll know more once we get the labs. But right now, I want to hone in the heart and the lungs for now. And with his travel history, I think we're all probably with our type 1 thinking, could this be a PE? With his history of cancer, he definitely is in a hypercoagulable state. But the other thing is, I've been taught that dyspnea with cough typically is a pretty good indicator that this is coming from the heart. From the lungs. But we don't mention anything about cough. In fact, she denies cough. That's a rule of thumb, and it's not always pans out. For example, certain types of heart failure, if the left atrium is enlarged, can impinge the recurrent laryngeal nerve and lead to a hoarseness and a cough. So it's not foolproof, but it is one of the clues that you can get in the initial HPI that can make you wonder, that is this the heart that's contributing to this, especially with the lower leg edema. Now, I don't want to make too much of the edema right now. Obviously, this could be a sign of fluid overload state in this individual. And that obviously could be in the side of either, is this the liver, is this the heart, is this the kidneys, and in rare cases, protein losing enteropathy. We don't have any history of diarrhea, so that seems less likely. We'll get more information with the labs to see if that is actually true. But the reason why I'm saying that I don't want to hone in too much of the lower extremity edema is that it could just be secondary to venous stasis dermatitis, especially after a long travel. I think the teaching or the scribe just went away. So I'm trying to like go off my thoughts here. So I think the one thing here is the cytarabine. I think, Joel, you said it was an anti-DNA type of chemotherapy agent. The one other medication that I think of when I think of that is methotrexate, and we know that can cause lung fibrosis. So I do wonder in this case, could this be, and I don't know the time course here, like how long he's been on captocytarabine. So I would want to know more history about his cancer treatment and like how long he's been basically taking this. And some chemotherapy medications are not even like around when they get initiated. Some are dose dependent. For example, doxorubicin, more doses you get, more likelihood of cardiomyopathy. So maybe this is a similar time frame where like the accumulation of these doses have led to like some type of pneumonitis. But again, the lack of cough makes me wonder like otherwise, but I don't know, perhaps it led to a cardiomyopathy. I'm just, this is a gap in my medical knowledge in terms of this chemotherapy medication. So to summarize, I think with his travel history, initially I would be thinking about PE, and I would be kind of seeing if, could this be, is this heart related versus lung related? But I would love to hear Jeff's approach and in his initial thoughts in this situation.
I don't have a whole lot to add. I'm thinking in terms of formulating the situation here. This is a generally, it seems to me, although he has a history of cancer. You said elderly, 66, late middle age, and with
sorry, Jeff.
with really dyspnea on exertion, and that's one of the things that sticks out to me. It's real, he's not dyspneic at other times, it's just on exertion. So that makes me think more about cardiac type stuff. Like, is there something that's happening when he needs an increased cardiac output that is not happening when he doesn't? So what makes this dyspnea unique? Just 4 days, it's on exertion. He's on a weird medicine, which can have cardiotoxicity. He's got a headache and abdominal pain, which doesn't usually go along with that either. So all they could be, dead herrings, but that's kind of what the little things that pop up and say to me, oh, should we think more about this thing or that thing? For some reason, the chemotherapeutic agent hits me, but I don't think that we would necessarily approach this initially any different because he has enough of the risk factors, like you were pointing out, with thromboembolic disease and so forth, that we'd probably take our standard approach when we first start, but to keep our differential broad.
Yeah, and I think what I'm glad you mentioned the abdominal pain and headache. I kind of totally glossed that over. I guess one of the reasons is because it was probably like non-specific, but you're right, it could be a systemic imprint from his chemotherapy. And not to anchor too much on the chemotherapy, the other thought that I was wondering that, he is immunocompromised, and we didn't really talk about infections, especially indolent infections that can brew over time, could potentially lead to either myocarditis or even pneumonitis or even pneumonia. So yeah, I think that was great. Joel, we're ready for more.
Yeah, this is what I love presenting to you guys. That was so much discussion from just the HPI before we even got into a lot of the objective data. I can tell you kind of my head was in the same place. I was also leaning a lot towards cardiac. I was wondering about AFib, symptomatic aortic stenosis, congestive heart failure. I felt like I really needed to see him, get a volume status, was kind of going to guide a lot of my next steps, and also to see if he was hypoxic. When people talk about dyspnea, it can mean many things to different people. So I wanted to kind of see some of that objective info. And I also felt very compelled to have a super low threshold to treat for PE. That was like one of the alarm bells that was going off for me. So the second aliquot is the physical exam and some of the initial ED labs and imaging. And then I think it'd be a good time to, again, have a new problem representation or reframe how that changes the initial conversation. So his vitals were notable for hypertension with a blood pressure 186 over 110, no history of hypertension, pulse 102, which on outpatient vitals is usually a normal 60s to 70s type heart rate. He was afebrile with a temperature of 98.8 Fahrenheit. His respiratory rate was 20. His SpO2 was 93% on room air. And just so you can get a better picture of him, he has a BMI of 22. And on my exam, he was quite well appearing. He was laying comfortably in bed, very kind and cooperative. He had a non-contributory HEMT exam. He had no JVD on my exam. And his cardiac exam was also quite unremarkable. I didn't hear any murmurs. He had a regular rate and rhythm. Sorry, he's a bit borderline tachycardic, but he had a regular rhythm. And his pulmonary exam was also quite normal. I heard completely normal breath sounds throughout his posterior lung fields. He was not working to breathe well in room air. Really, the only abnormal finding was just trace pedal edema. It was a very small amount, equal bilaterally. So I felt based on his exam that he was quite euvolemic. His labs, they did a CMP, which showed sodium 135, potassium elevated to 5.2, chloride 98, bicarb 21, BUN elevated to 26, creatinine elevated to 3.40 with a GFR of 19, glucose 120, calcium 9.9, albumin 4.5. His AST was elevated to 173 and ALT elevated to 105. Normal bilirubin. His CBC showed white blood cell count of 9.5, H&H of 13.2 and 41. And he had a BNP of 26,000 and UA notable for 3+ protein and 3 to 10 RBCs. And the initial imaging that the EKG did, or that the ED did, was an EKG that was sinus tachycardia and a chest X-ray that showed no acute disease, no effusion or edema, no nodules. I think this is a good place to pause to talk about how that exam and those labs and imaging guide you. And to answer the chat, there was not a triple collected at this point.
You want me to start? Jess?
Jeff, do you want to start this one?
Sure. Okay. So, the physical exam is disturbingly normal. It seems that we're not picking up too much there other than the tachycardia and hypertension. I didn't really hear any of the findings that made me change my thinking. The labs are notable for the acute or chronic renal disease, but obviously something going on with his kidneys. So that we have to pay attention to. Let's see, and then
let me interrupt you real quick, Jeff, because there's one thing I wanted to point out is that he happened to have an outpatient CMP just 1 week before that was completely normal.
Okay.
So I think that's helpful for discerning the time course.
So this is an acute thing that's going on. Obviously, his heart's not happy because he's got the elevated P and P. So now we start to talk about chicken and egg. So is he retaining volume because of his kidney failure and therefore his heart is strained, or is his heart not working because his kidneys not working, his heart's not working, or something attacking both of them? He's not hypoxic. The thromboembolism is getting a little bit lower on my list here. I'm thinking more like some sort of more systemic type thing that's happening to him that's causing this problem. So what do I want? I want a little more assessment of his heart. And you need to define what's going on with his kidneys a little bit more too. Your analysis did not have any proteinuria, correct? So
Pardon?
There are a few red cells, but I didn't hear that there was any proteinuria.
There was 3+ protein.
Oh, there's 3+. I'm sorry. Okay, so there was. It's probably on that screen. Oh, there it is. Thank you. So I'm worried about that, and I think we need to define that too. Jez, you want to add?
Yeah, I just want to clarify: was the glucose 20 or 200?
120.
Oh, 120. Okay. Just wanted to make sure. All right. Yeah, I think this is perplexing in multiple ways because when I look at that UA, the first thing I think about is, is this like a glomerulonephritis type of picture? But then the AST is more greater than the ALT with a normal Billy, it seems like. So it's like, okay, so is this coming from a secondary source? I would, is hemolysis possible? I would be very shocked to see that if this is hemolysis with a normal Billy. Now, that creatinine is a pretty significant jump. And like the first thing that you want to think about is like pre-renal disease. And that can explain why he's hemoconcentrated with his hemoglobin of 15.2 and 41. That being said, why is he hemoconcentrated? Is it just because of decreased PO intake, or is that, or he's euvolemic like Joel's exam, truly euvolemic? And 15.2, I understand that's not like absurdly high, but can this be a form of like an EPO secreting tumor, which can also lead to thrombosis? I think, Jeff, this ties to your experience. I'm still concerned a little bit with PE just because he is tachycardic and he's hypoxic for some reason with a normal chest x-ray. Now, an x-ray can miss a lot of things, and I would want to get a CT scan in this individual specifically. Like, for example, he's hypoxic, his x-rays are fine, he has an elevated BNP. I wonder if this is cardiac strain secondary to a PE that is leading to the elevated BNP. And is explaining his syndrome of dyspnea, hypoxia, and even hypertension. But I'm trying to connect everything together. And in medicine, too many times we try to connect it with, the term goes Occam's razor, where like the simplest explanation is the most likely the correct answer. But sometimes it follows the philosophy of hiccum dictum. So and it could be the latter, but if we're trying to apply Occam's razor here, could it be that he actually has nephrotic syndrome? But what makes me pause there is that he's not fluid overloaded. But where I was trying to connect it was, does he have nephrotic syndrome? And that led to him having a predisposition to have a clot, which led to his PE. But again, there's certain things that just doesn't fit. And Jeff, you pointed those out. So, but with the low albumin and 3+ protein with RBCs, I would really want to see if there's any red blood cell casts or dysmorphic red blood cells. For the fact that he had a normal CMP a week ago and now he has a creatinine 3.4, I would be very hesitant to chalk that up just to pre-renal. I would say this is a component of intrinsic. And with that BU, I know the BUN to creatinine ratios are not that reliable, but looking at that one, that's pretty 1-to-1. So I'm worried about a nephrotic/nephritic picture in this situation that may tie in the potential dyspnea. But the other thing that we haven't talked about, maybe he's not hemoconcentrated, but maybe he has hyperviscosity syndrome from a secondary cancer, which can explain the hypercalcemia, the elevated hemoglobin and hematocrit. And the hyperviscosity can lead to his dyspnea. So there's a lot of moving parts here. And it's funny, Jeff, we went from this probably could be the side effect from the cytarabine or whatever it's pronounced now to like, could this be secondary to something else? So now we still need to figure out what the trigger is if this is nephritic/nephrotic, because we don't know that. It could be malignancy, could be other autoimmune conditions. So a lot of moving parts, and I'll be honest, like it's a little perplexing, but with tachycardia, hypoxia with no cause, I do want to hone in on the vasculature, specifically the lung vasculature, to see if this is a PE.
I'm glad that you guys felt somewhat perplexed at this point, because this is when the patient was admitted to me. I was moonlighting. This was like midnight, where I had to go see him and just kind of get him tucked in best I could. I had a lot of similar thoughts. The BNP elevation was striking, given that his exam was completely euvolemic for me, except his trace edema, which I ended up kind of attributing to maybe this renal disease. But his chest X-ray, my exam was not consistent with CHF. I didn't think that he needed to be diuresed. I was concerned about this representing heart strain, as well as his decreased GFR could cause some elevation of BNP.
Yeah.
But I treated him with therapeutic heparin, as one of my initial interventions, and then also wanted to gather a lot more info. Somebody in the chat mentioned the blood pressure and kidneys potentially being related, which I also thought was interesting, that his blood pressure was like 180s systolic with no history of hypertension, maybe contributing to some of the headaches that he was describing. My focus kind of shifted towards the kidneys because I was like, okay, well, I'm going to call this a likely PE. His Wells criteria is like 7-ish, very high risk. I couldn't get a CTA given his renal function. So I just treated that. And then I was like, okay, why are the kidneys this injured? So some of the data I gathered that I'm going to talk about in Eloquat 3 is kind of my initial workup. And then I'll go through some of that and allow you guys to share where you would go next based on that, those results. So I gathered some more labs. I was worried because there's like signs of multi-organ damage at this point, and there's, I couldn't really explain his LFTs. His bicarb was low normal, anion gap was high normal. I was worried, like, is he a little immunocompromised? I got a lactate and a VBG that were normal. I ordered renal ultrasound and urine lights. I won't give you all the details, but I was, thinking about glomerular disease. I ordered an ANA, ANCA, complement levels. They were all normal. His urine lights showed, like when you could calculate his FeNA and FeUria, and it showed intrinsic disease most likely, which I think Jazz kind of mentioned is evidenced by the BUN to creatinine ratio. I think we so often see pre-renal disease with a really high BUN that wasn't there for this guy. I ordered an echo, like Jeff said, just given his dyspnea and the BNP. So some of these results, I ordered a VQ scan, but also bilateral lower extremity Dopplers, just given it was like midnight. I didn't think the VQ scan would really happen quickly. But the Doppler ultrasound did result in revealed bilateral lower extremity DVTs. The renal ultrasound, they said that the left renal artery was not well visualized and can only be demonstrated near the hilum where waveform relatively dampened. Consider further evaluation with CTA or MRA. I ordered a right upper quadrant ultrasound because this was a new transaminitis, which showed some stable hepatic lesions that were previously characterized as hemangiomas, but they also said additional hypoechoic lesion at the hepatic dome that was not seen on the prior CT and not fully characterized on this exam. So they recommend dedicated CT or MRI of the abdomen. And then the echo was basically normal, not completely normal, but normal left ventricular size and systolic function with a normal EF of 60%. There was dilation of the right ventricle with mildly reduced systolic function and some biatrial enlargement. And just some mild valvular disease, nothing contributory, and mildly dilated proximal aorta. And these results all came back, except the echo, but most of these results came back overnight where I had to see them and kind of decide the next step. So I wanted to pause here and see where you would go given this initial workup and the patient still fully in your hands without anybody on board in the middle of the night.
Sorry, could you repeat that question, Joel?
Just how you're overnight and these results are trickling in at 4 or 5 a.m. You're about to hand off to the primary team, but you need to follow up on the initial first pass that you ordered, and I guess where you would go from here, and if any of this changes your train of thought. It's going to be kind of a brief discussion, and I'll give some more info in the fourth aliquot.
Okay, Jeff, I can get this one started and then give it to you afterwards. So I guess like if I'm taking care of this patient in the middle of the night with reduced staff, I think, Joel, you hit the nail on the head in terms of starting the treatment with heparin. I'm impressed you got the ultrasounds done in the middle of the night, and usually this ultrasonographers are not working that late. So that's the most impressive part of this aliquot. But the fact that it showed bilateral DVTs, this increases the risk of throwing more clots to the lungs. So I would have done therapeutic heparin in this case. So kudos to you that you actually started it before that result came in, especially with the AKI. It would have been hard to get a CTA with contrast. So I would have done that. I think I would have also really start looking for the etiology behind the elevated creatinine and the AKI. Seems like you did some good workup. Obviously, this took time to return, but I would have definitely ordered the ANA ANCA as well, in addition to the complements. Honestly, it's hard to answer this because this is overnight and it's first pass. I don't think I would do it first pass. Maybe I would defer this to Jeff, but I would probably consider CT abdomen, just considering his history of cancer and does he have new lesions? Does he, why is he why is he hypercoagulable right now? Is it connected to the kidneys? Or is it because he has reoccurrence of his cancer? And I think we all know this as another rule of thumb is that individuals who get one type of cancer are at risk for getting another type of cancer. So I think in that situation, I would want to start off with the CT abdomen that might show a nidus behind why he's in a hypercoagulable state. I personally find it less likely for him to have a DVT that is attributed to a 5-hour drive to Pennsylvania that is bilateral and even during a PE, but I guess that's possible. But I would use that as a diagnosis or a reason of exclusion until I rule out other potential causes for his hypercoagulable state. But Jeff, would you do anything differently if you're taking care of this patient overnight?
Not anything overnight, but just thinking about what the next step is. I mean, there's that weird finding that Joel made reference to on his, is that his ultrasound, that there was something strange about his vasculature because something not his artery.
I can read it again. The renal ultrasound. So they said, the left renal artery was not well visualized because, so I didn't clarify, this is renal ultrasound with Doppler. The left renal artery was not well visualized and can only be demonstrated near the hilum where waveform is relatively dampened. Consider further evaluation, blah, blah, blah. But yeah, that was something I hadn't really seen in the past.
So, on his echo, so are there clots everywhere in hips? Is one question. I mean, are his kidneys not working because there's clot there, and is his liver not working because there's clot there too? So I agree with imaging, but I probably want to go for vasculature almost more than parenchyma of these organs, given what's going on here, and thinking, is there something that this guy is just clotting all over the place right now? There wasn't anything said about, I don't know if this was a study done that had looked for, communication between his left and right heart, but on the echo, are clots getting across into his arterial circulation? Would be a thought. So how is this all happening? So I guess I would agree with more imaging, but I'd want to do it more with vasculature. And then I'd probably actually go to some resource and start looking up what kind of things could cause systemic hypercoagulability that I'm not thinking about right now. What am I missing here? I don't have enough of a list of that in my head to just roll those off. But the other thing, Joel, did he have a urinal? Did he have a micro? Were there casts in his urine? Was there any?
I was going to talk about the next aliquot, but no, there were no casts. Yeah, I think it was brewing at this point, but nothing ended up showing up.
So I don't think I'd change anything that you did, and I would try to figure out what the next step was to figure out to move this along in a way that I'm not missing something that needs to be treated right now.
Yeah, and then just to add to that, Jeff, I agree with you. And you bring up a good point with the left renal artery not being fully visualized, like easy throwing multiple clots. And usually that comes from a source. And is this the heart? But it seems like the echo did not have any evidence of a vegetation. But sometimes we know that the echoes, TTE at least specifically, can miss clots or vegetation specifically. And a TEE might be reasonable, but we would have to need more evidence to see if there is multiple clots in multiple areas. And if that's the case, then maybe a TE would be warranted. In terms of like what's causing the hypercoagulable, cause kind of, I know that was second part of Joel's question, is like, he doesn't have any evidence of hemolysis, no thrombocytopenia. So I'm not concerned for like a MAHA type of picture. This is way too fast for this to be like a PNH or paroxysmal nocturnal hemoglobinuria type of picture. Vasculitis could be possible, but I think when we're stuck, or when we're like kind of thinking about what's causing this, I think really focusing on who the patient is, and in this case, having this history of cancer, I do wonder if there is some type of occult malignancy that we're missing here, especially with his hemoglobin of 15.2. Like I don't know why I'm fixated on that, but if this does not improve with IV fluids or whatever, it's just, if we've noticed that it's always been high. I know that's not high, it's the upper limit of normal, but I am wondering if this is a secondary type of like polycythemia from a malignancy or some source from there. But I would love to get more information to see where he was going with.
Yeah, you guys this is excellent discussion. The next aliquot doesn't fully reveal the diagnosis, but basically I'm gonna fast forward a couple days, because what ended up being ordered, not by me, because most of this got handed over to the primary team, but on an MRA abdomen, since a couple of the studies recommended something like that, and they wanted to view the vasculature. Nephrology was also consulted. And it's a good thought in the chat about antithrombin 3 levels. They did recommend checking that. And it was all pretty unremarkable workup. So nephrology, let me back up a little bit. So I'm going to give aliquot 4 now, which will include some of the imaging findings and reveal a lot of new info. And then I'd like for you guys to try to come up with a explanation of piecing it all together after that. And then I'll reveal the diagnosis in the following aliquot. So nephrology was consulted. They did a lot of these studies. They thought that glomerular disease was unlikely. They commented on the right ventricular dysfunction on the echo, that this could be cardiorenal syndrome, but again, a lot of the other cardiac syndromes weren't there. They were a bit puzzled. They wanted the MRA abdomen as well. And they said that if the MRA abdomen was non-revealing, that they were going to go to renal biopsy. Because also at this point, the creatinine was pretty rapidly elevating. So by day 3, it was like 5.0. And so they're starting to have like the dialysis talks if this trend continues. So they were ready to do biopsy if they couldn't get a result on the MRA. And so what the MRA abdomen ended up showing is multiple areas of thrombus within the abdominal aorta, celiac artery, superior mesenteric artery, and renal arteries. They commented on the status post Whipple. They said that there is a lobular zone of intermediate signal between the pancreatic remnant and abdominal aorta. Findings may be due to metastatic disease or may be inflammatory from post-treatment changes. Those are the really only pertinent findings. And again, also by this time, his LFT is completely normalized. That was kind of one of the most puzzling pieces of this for me, is that they had like a whole right upper quadrant ultrasound. They had the hepatic panel, the hepatitis panel, and everything was normal, and it just got completely better. And so after seeing the MRA abdomen results, some of what made sense for me is the blood pressure still being high. At this point, his blood pressure never really went down. His systolic was like 180s, 190s this whole time, which the team was kind of not treating aggressively to maintain perfusion to the kidneys, which were the focus at this point. But maybe given the MRA findings of the multiple arterial thrombi and this this signal between the pancreatic remnant and abdominal aorta, how that might help you hone in on a final diagnosis here.
Joel, do you mind, what did you say was normal? And that you said puzzled you? I missed that.
The LFT is normalizing.
Oh, they're normalized. Okay.
Yeah, his transaminases just went away.
And did the VQ scan ever result?
So the day team ended up canceling that, I guess, and I don't really know exactly why. I think there was some comment about the degree of right heart strain maybe skewing the study, and the Doppler ultrasound and the history being enough to treat for PE regardless. Okay. But I will comment a little bit more on that, some of the follow-up.
Okay. Jeff, do you want to start this one?
No, but I will.
Okay.
So tell me this finding, this thing between his pancreatic something or other and
Yeah. So a lobular zone of intermediate signal between the pancreatic remnant and the abdominal aorta, which they said could be metastatic disease or inflammatory. A lobular zone of intermediate signal. And I think Maddie made a good comment as well. I'd be curious how your problem representation has changed at this point, because each aliquot for me was kind of shifting my focus. And I wondered like now how you would characterize this patient given the info that you have.
So I can give that a stab. It's a little overwhelming here, but so basically this is a case of multiple thromboses in both veins and arteries. So it's kind of interesting. It's not, there's thrombosis everywhere. Polycythemia. Let's see, I mean, dyspnea and exertion is not just a symptom, it's more the, let's see, and acute renal failure in a person who has a history of cancer and is still being treated for that cancer, and also has a strange finding in his abdomen adjacent to his pancreas. I don't know, Jess, what do you think about that?
Oh man, I think for your problem representation, that's excellent. I have nothing to add for the PR.
And if I could just jump in with a quick question, Jeff, you talked about how one of the striking findings was the fact that there are multiple thromboses in both veins and arteries. And I was wondering if you could talk a little bit more about that, like why the fact that it was both veins and arteries stood out to you.
Well, I mean, with arterial thromboses, I think about vasculitis, for example, because there's inflammation and disturbance of flow as a result of the inflammation. But that's, vasculitis is usually predominantly an arterial disease, not a venous disease. So this guy has in theory, lots of clot burden in his veins, but then lots of stuff in his arteries. So either the clots in his veins are passing through a PFO, which didn't show up on the, and showering into all sorts of other places, which I suppose is possible. I don't know if they commented about it. They said, Joel, on the echo, if there was any comment about that, or if it's done with contrast to be able to make that diagnosis. Or there's some other connection, weirdly, between his aorta and his vena cava. I don't know. That would be a strange thing. Maybe that thing in his abdomen is some sort of a connection between his venous and his arterial vasculature. Or includes something there. So that's it just strikes me as odd that there's both those phenomena going on. So either he's extremely hypercoagulable, or there's some connection between what's happening in his veins and arteries.
Yeah, and I agree with that totally. And like the couple of things I think of arterial clots for me is like, history of cancer, and then you have like certain types of autoimmune conditions, PNH, and then HIT can also lead to arterial thrombi, but he came in before getting heparin here in the hospital. And then antiphospholipid syndrome is the other thing that I think of that can lead to arterial thrombi. But again, I guess it's possible, but I'm not really getting that flavor here. But I guess it's not a bad idea to check for antiphospholipid syndrome in this case. I guess it's time to probably talk about narrowing our differential, Joel.
Yeah.
Has he had the whole? Oh, go ahead. Has he had the whole? Hypercoagulable workup. I mean, you told me of the little pieces piecemeal, but has he really had the full spectrum of everything done?
Not at this point. He did get a full workup that was negative,
Okay.
including like JAK2 and antiphospholipid syndrome, antithrombin 3, all the factor 5 Leiden, the gene mutations, the works.
Yeah.
But I will say that you guys have said the diagnosis in your discussion. So well done. Would you let-
So Jeff, let's like kind of hash this out a little bit. So I think going back to who this patient is, I think he's at risk for another malignancy or recurrence of the same one, considering the differential in the MRI was considering metastatic lesion. I don't know, Jeff, what are your thoughts on this? I wonder if this is an EPO secreting tumor. Joel, do you mind commenting on the hemoglobin hematocrit? Did it go up? Did it come back down? Or did it just stay in the higher limit of the normal range?
It was pretty much normal the whole time.
It didn't go lower than 15 and it didn't go higher than 15 for the hemoglobin?
I can glance at it, but let's see. Hemoglobin. It was like 13-ish most of the time.
Okay, so then that's less likely then.
Yeah.
So Jeff, I would love to know your thoughts here, but I think that this is either a recurrence of his cholangiocarcinomas, because from what I remember, those are pretty aggressive. And even if you do remove them, there could be microparticles of the cancer that could have just taken time to grow. Or this, his history of cancer puts him at risk for further cancers, and he has another cancer. And given the location, I would be worried about pancreatic cancer. And I believe, if I remember this correctly, pancreatic cancer is one of the most common, the most thrombotic cancers there are. So, and if he has multiple clots, and this turns out to be pancreatic cancer, or from the pancreatic remnant, so I'm thinking about that, but what are your thoughts there, Jeff?
Right. So I want this to be something common, but I would probably go and talk to the radiologist and ask them to go through that, whatever that thing is adjacent to the aorta, and look at it more with me and say, what in the world is going on there? Because I really wonder about if this is some sort of shower of emboli that's happened. And is there any way that the radiologist could say this is not any sort of connection here? Because it's an MRA, so you should be able to see, but I don't hear them saying yes or no, like there's no blood flow from the aorta into this thing, or, oh my goodness, look at this. So I want to really talk to the radiologist and make them look at the image with me and help me understand that, because there's something really odd going on here. The other would be to ask the cardiologist to look at the echo. It just feels to me like it's so acute. Like there was this shower. And the other thing that makes me think about that is the fact that the liver functions got normal again. So like something hit the liver, and then it recovered from that. The kidneys not so much, but maybe they got a bigger burden. But and it doesn't. They have smaller, relatively, one feeder rather than they can absorb as much of a hit, I would say. So underlying hypercoagulability, it doesn't sound like we have it, at least not in the testable range. I mean, 50% of them aren't really, there's no test to show us what's going on there. So it still could be just plain old hypercoagulability, but there's something about how this happened all of a sudden. Like he didn't have a few clots, then a few more, and then a few more, just like bang, hit him. So I'd probably phone a few imaging friends before I ruled out the fact that thing in his abdomen is something. And I guess the other thing to think about is, which we haven't talked about, is that his vasculature has been arranged when his guts were rearranged with his procedure there. That's so true. That is another factor.
Yeah. I agree with everyone that like it is definitely acute, but I also want to keep in myself in check in the fact that, you know, could this have been a process that, you know, it's like that analogy, like the pencil rolling off the table, like, you know, it presented acutely, but underneath over the past few months was this just brewing to the point where it just overloaded. So yeah, it would be interesting to see what the final diagnosis was, but I'm reassured to know that we said the diagnosis somewhere in our discussion. Hopefully we won't be
Yeah.
over, Jeff. Oh, 1 for 2. I'll take it.
So let me take us home for the sake of time. You guys have gotten the diagnosis. You have redeemed yourself. I'm going to kind of fast forward a little bit, and I intentionally withheld some info that Jeff specifically commented on because
Rascal.
there's a lesson to be learned in that the echo was continuously commented on. Normal echo. Vascular surgery ended up being consulted after all the thrombi. They called radiology, like Jeff said. They talked about this finding. They were really concerned for recurrent malignancy. And they also discovered that the bubble study was never done on the echo. And they were concerned for shower emboli, paradoxical emboli, hypercoagulable state, malignancy. They ended up getting a repeat echo that showed a PFO. And just to kind of fast forward even further, he ended up getting a PET scan after this hospitalization that showed recurrence of malignancy at the pancreas that they attributed to all this. In the meantime, he ended up on dialysis for 3 weeks, but got pretty solid recovery afterwards. His most recent creatinine is down to like 1.5. He also in the hospital developed a severe acute GI bleed where his hemoglobin went from like 8.9 to 5.7 overnight, and it was a whole ordeal. But he ended up discharged on Lovenox, which he continues on today, 6 months later. He got radiation, is on a new chemo regimen, and based on chart review, appears to be doing quite well. He ended up seeing hem-onc for the coagulopathy workup that was non-revealing. They attributed this all to the malignancy. And his blood pressure also improved over time. He ended up just on 10 milligrams of amlodipine. And so that is the diagnosis: recurrent malignancy through venous and arterial clots, partially related to this PFO. And I think somebody in the chat had mentioned that maybe there was a bigger thrombus that tipped him over, whether it was a PE or the renal infarct, something that now made this appear acute. Because when vascular talked to radiology, they had said that the appearance on imaging was more of a subacute picture. So well done.
Wow, what a great case. I just have a question. So then I think someone asked this too. So it was the etiology for the AKI because of a clot in that artery that they were not able to visualize? Yeah,
that early ultrasound that you guys commented on was a sign that they had that disturbed waveform. They basically just had like an arterial stenosis, and they got the severe renal injury and the hypertension as well related to that.
Wow, what a great case, Joel.
There's a lot of
Joel,
learning.
Yeah, Joel, I just wanted to turn to you to see if you had, just to see if you wanted to share like anything that you learned from this case, like what was it like taking care of this patient, and any kind of key learning points you wanted to highlight.
Yeah, certainly. I mean, one of the big takeaways, obviously, I kind of mentioned is confirming some things yourself, like this PFO. You know, obviously Jeff had something in his head that's saying, why was that so normal? Something's going on. This is weird. It's venous, it's arterial. Let's back up a little bit. And it took like day 5 until a new consultant came in and re-looked at the picture and was like, well, duh, you need to get a bubble study. It was helpful for me to be able to continually reframe my goals because, I mean, again, I wasn't part of the primary team, but in reviewing this, is what this patient came in for. The dyspnea ended up being just kind of a background subjective problem. He never had an oxygen requirement. We're never treating hypoxia. And then it became, he has this kidney injury. Now he's hypercoagulable. Now he maybe has recurrent malignancy. Now he's on dialysis. And so being able to reframe was really huge for me. And recognizing how not like everything is sometimes there's like separate problems that may or may not be connected. And so there was a point where I was like, maybe this guy is just cancer. He is just hypercoagulable. He's getting venous clots. He's getting arterial clots. I didn't even really think that about the PFO being there. But it's still kind of separate problems with a common etiology that end up coming together fairly nicely. Yeah, there's a lot in there along the way. I think a lot of it's nicely written down and the teaching points there.
Yeah, Joel, thank you so much for preparing this case and presenting in truly an expert way. It was quite the ride to kind of hear all the aliquots. And I just want to turn to Jeff and Jazz if you had any kind of last reflections about what it was like going through this, and then we'll finally turn the mic to Yasmin for teaching points. But go ahead, Jeff, any final reflections?
No, it felt like the real world, and in terms of the uncertainty and trying to figure out how to manage uncertainty, but also move ahead with treatment at the same time. I thought that was a good real life example of this. And yeah, it's don't have much more to say. I know initially I wasn't so convinced about a PE, but obviously once that was established, we had to, that sort of threw us all in the correct direction to start to look at what this is all about. So I don't have anything else to say. Jazz, go ahead.
No, I think this was a great case. Thanks, Joel, for preparing it, and thanks for everyone here to having us as a guest presenters. I think this was a great experience. Definitely very nerve-wracking, but I think nerves eventually settled throughout the discussion. But yeah, just wanted to say thank you to everyone for having us. I think this was a very great experience for all of us.
Yeah, just want to kind of just echo kind of the huge thanks for Joel and Jeff and Jazz for really your expert discussion. It was really cool to see how you kind of navigated the uncertainty with this. And Jeff, as you said, kind of in this case, importantly, navigating both the diagnosis and the management throughout. So really learned a lot from this. And Yasmin, we'll pass it to you for teaching points.
Yeah, thank you so much, everyone. I am very glad to have listened to this amazing discussion and really enlightening with every single twist. And thank you, Dr. Joel. I hope that you will be presenting more cases to us, and Dr. Jazz and Dr. Jeff, we hope that we can have you here again as discussants. Now for teaching points, we started approaching to dyspnea. Like, what could we have to look at we have to characterize dyspnea looking at our patient's past medical history and what is the concomitant signs and symptoms. For example, if this patient had lower limb edema, look for signs of liver and kidney disease. If there is a protein loss, even protein losing enteropathy, which might be a little bit more difficult to find, but just keep it in mind. Now, travel history, could this be a pulmonary embolism due to his travel history, or due to his cancer past medical history? Could this patient have hypercoagulability or drugs that could cause lung fibrosis or cardiotoxicity, or any other infections, especially in patients who are immunocompromised? Also, when you're looking at dyspnea, if this is accompanied by exertion, you can think of cardiac issues. You can also look at hypercarbia or hypoxia. Now, looking at the labs of this patient, we had a big question. Is he retaining volume and therefore his heart is strained, or are his kidneys having issues because the heart was not working right? So we looked at the urinalysis that showed protein. And again, we could think glomerulonephritis, kidney issues. Liver enzymes were elevated. So we could also think, is this hemolysis? High creatinine and the bond creatinine ratio, we could make us think of pre-renal diagnosis. And altogether, we got another question. Could it be nephrotic or nephritic syndrome that could take us to hemoconcentration or loss of antithrombin 3, which could have hypercoagulability? Or is this a malignancy that can cause hyperviscosity? We had to think about it due to hypercalcemia, high creatinine, protein in the UA. Now, remember that there is a high risk of cancer recurrence, especially in aggressive cancers such as cholangiocarcinoma and pancreatic cancer. And now With approaching to the MRI findings, this arterial thrombosis can suggest vasculitis versus a hypercoagulable state. And if you think about vasculitis, you can do a workup looking for lupus anticoagulants and antiphospholipid antibodies and such. And for last but not least, when you have a patient with a past medical history of cancer and hypercoagulability, do not forget to ask for a bubble study during the echo. That could save a lot of problems to the patient too. So these are my teaching points for today. And again, thank you all. Back to you, Maddie.
Awesome. Amazing teaching points, Yasmin. You summarized that so well. Well, thanks everyone for tuning in. Again, Joel, Jeff, Jazz, truly an amazing case and case discussion. And we'll see you all next time. Take care, everyone.